Okay, everybody, I'd like to introduce you to Dr. Matthew Eschelbach. Dr. Eschelbach is our Assistant Medical Director, and he is actually going to be transmitting to us tonight from Redmond, Oregon. He is the Medical Director for St. Charles Emergency Department, as well as several emergency response organizations in the Oregon, lovely state of Oregon. He teaches quite a bit, I believe, on at least the national circuit. I don't know, do you do any international lectures, Dr. Eschelbach?
No, I don't do any international lectures.
Okay, well, national's good enough.
This is considered international by your standards.
Well, this is true. This is true. Okay, so wow, looks like a very good topic tonight with challenges with the bariatric patient in EMS. Folks, I'll be kind of paying attention to you over here. We keep our microphones muted just so that there's no ambient noise and you can all hear Dr. Eschelbach. If you have a question, there's a way you can hit to raise your hand on your screen or type in. Or if it's just you, you can also unmute your microphone and, jump in and ask a question. Just after you've asked the question, please mute your microphone again so that we don't get your ambient noise. That having been said, I'd like to turn you over to Dr. Eschelbach.
All right, good evening. Welcome, everybody. I hope everybody's staying warm. We're going to talk about bariatric patients tonight. In my research, you don't get to talk about this much while you're in school. It's kind of a challenge that you run into after you left school and you're actually in the working world. But like everything I do, we'll start out with just a little bit of humor. I'll pre-warn you, there's a couple of videos in here, so if you've got sound, make sure it's on. And I'll also warn you that what I find funny, you might not, but that's okay. Just try and keep an open mind because we're dealing with a difficult topic. So it's part of our everyday life, obesity in the obese patient, not in just the United States, but now throughout the world. If we consider ourselves caregivers, we must strive to treat all patients with respect, dignity, and professionalism. And we do that in the moment every time we treat a patient. We're dedicated to fighting disease in our profession, and obesity is a disease that we must fight every day. And we'll talk a little bit more about that as we talk about different aspects of obesity. And I truly believe through all things humorous, we can cure our body. Laughter is the best medicine. So on Saturday mornings, my father used to love to take over the TV and watch Roadrunner cartoons. And this is what I would see. Of course, the Roadrunner was always over the coyote, always won, never lost. So with those same sound effects, there's a little bit of modern day Darwinism. All right, so in this instant YouTube world, this was actually taken in by some base jumpers in Russia, I believe. And my understanding is that patient actually lived, just had multiple fractures, back, pelvis, chest cavity, actually survived the jump. All right, obesity in the United States, we see it and run into it every day. Here's a picture from the New York Times of a heavy couple who had, in the streets of New York, had rented a kind of like a rickshaw type device, and they were too heavy. and tipped over, and we had to wait for EMS to respond and then bring them to Roosevelt Hospital. This is from London, emergency workers who had to actually take somebody out of their home by breaking through the wall of the residence, and we'll see a similar case later on in the talk about that, to get her out Friday, and that was in the United Kingdom. Here is a picture of a 600-pound man who needed to be cut out of his home by paramedics and firemen to rescue and take him to the emergency department in southern Pennsylvania.
It's a shocking case of a morbidly obese man who literally had not left his chair in 2 years. When he couldn't be wakened on Sunday, Nest's E-Squad responded to perhaps the most bizarre call of their careers. Not only did he have to be cut out of his chair, but they had to cut a hole in his house to get him out. Now the 43-year-old Bel Air man is in Wheeling Hospital fighting for his life. 7 News reporter DK Roy joins us from Bel Air with the shocking details. DK?
This is a case that nobody wanted to talk about, at least not on camera. Off camera, they said a lot. They said the man was welded to his chair with urine and feces, that he hadn't left his chair in 2 years, that maggots were visible, that one police officer had to throw away his uniform after helping cut the man out of his chair. And this slab of plywood covers the hole they cut in the house just to get him out. Bel Air Code Enforcer Jim Chase says it was horrendous.
Well, the chair was outside. They had to take a section of the wall down in the house in order to get him out. The chair was very filthy, a lot of odor to it. Going in the house was not clean. The living room where the man lived in his chair was very filthy, very deplorable. It's unbelievable somebody lives in conditions like that.
Shockingly, 2 other able-bodied people lived there. Another man who had a separate bedroom, and the girlfriend of the man who was stuck in the chair. Officials say she served food to him since he never got up. Chase says now they have been given orders to clean it or leave it.
I instructed the landlord this morning and the other 2 tenants at the house, they have to get it clean. There's no way they can live in something like that, so they are working on it. So I'll be going back daily, checking on it, making sure that they get it cleaned up and it's livable. If not, they must get out.
One officer said it was the worst thing he ever responded to, and most said the worst part of all was the smell. Ironically, the landlord says the man in the chair rented from her before and used to be a vital, active person. She says when she checked on them lately, he always sat with a blanket over him. She had no idea it had come to this. Reportedly Sunday morning, his housemates called the E-Squad when he was unresponsive. Reporting in Bel Air for 7 News, I'm DK Wright.
Okay, so we're now talking about the morbidly obese patient. It's a condition, by definition, an excess proportion of fatty tissue and total body weight. Prevalence of obesity in the United States has doubled in the past 20 years, with 34% of adults being obese in 2006. The United States, believe it or not, has the highest prevalence of obesity worldwide, and with rapid increases. Obesity rates greater than 20% have been reported in the United Kingdom, China, and in Mexico. Here is a quick overview of CDC data on obesity from 1990 to 2006. You'll see on the left is 1990, where relatively high rates of obesity were 15 to 19% in the early 90s. And the only state of Colorado that escapes in 2006 from rates that are as high as 25 to 30%. So if you look at the 1990 rates, quite a few states had no data. 4 states had no data, but most of them were in the 10 to 14% range. And as we go later on, you'll see, especially in the South, higher rates up to greater than 30%. So let's talk a little bit about BMI. body mass index, or BMI, is used to define obesity. It's calculated by dividing the patient's total weight in kilograms by the square of their height in meters. For example, an average male with a weight of 80 kilograms and a height of 1.8 meters, that's just under 6 feet, has a BMI of about 25 kilograms per meter squared. And obesity is defined as a BMI greater than 30 kilograms per meter squared, and morbid obesity is defined as a BMI of greater than 40. Challenges in the obese: pre-hospital care must be delayed due to problems of moving and transporting the patients. You know, if you have to cut a man out of a house, that's going to take time. Appropriate size gurneys may not be ready to be available. Access to body fluids and body cavities is very difficult in some instances. Very often in the ER, we have to bring some of our most skilled nurses in and use ultrasound to get blood or start an IV. And morbidly obese patients have a different cardiopulmonary physiology, and we'll talk a little bit about that later. Life expectancy is shorter for those who are obese compared to non-obese patients. The difference is even greater for morbidly obese individuals. The higher rates of diabetes, high blood pressure, coronary artery disease, stroke, sleep apnea, DVT, gallbladder disease, kidney stones, and certain types of cancer are all higher in obese patients.
What's that?
It's Vespucia. I'm gonna show you how a bitch go down a slide. Mother of God! Hey.
All right, now humor aside, pathophysiology of obesity shows that they have a higher caloric intake, a lower level of physical activity, a lower level of metabolism. And these two things combined may answer some question as to why certain individuals can't get exercise or exercise as much, because it's kind of like a puppy chasing their tail. The lower metabolism leads to tiredness. Tiredness leads to decrease in physical activity, and it's a vicious circle. Some of these folks have a high insulin sensitivity, so they're not able to lose weight. And there is some research into something that's called an anti-obesity hormone. I'm not going to go into that too much, but there are some people who, we'll put it this way, I know everyone has this. There's a guy in the family or a guy in the group or a guy in the fraternity, a guy in the sorority who can sit there and eat everything in sight and they're still as skinny as a rail. That's just plain genetics. Where is that? How does that happen? And there are people who are, quite frankly, who don't eat excessively and they tend towards getting overweight. So we haven't got quite an answer to that yet. Someday, hopefully, we will. What this leads to is increased need for the body to put out a higher cardiac requirement. The heart has to work harder. Keep in mind that the person on the inside is still the same size, but lugging all that excess weight around, they have to work harder to get all that to the peripheral organs. You have usually a higher systemic blood pressure, increased resting cardiac work predisposes obese patients to left ventricular hypertrophy. Eventually, left ventricular hypertrophy can lead to heart failure, increased systolic and diastolic dysfunction, so they're going to have heart problems, and increased compromise in pulmonary function, including a decreased chest wall and lung elasticity, and higher airway resistance. Patients may find it difficult to breathe while lying flat because of increased energy requirement on the rib cage and in contact with the diaphragm. A lot of these patients might have a form of sleep apnea, and they might have to sit up and sleep up in the upright position. Increased work of breathing leading to compromised oxygenation and ventilation, particularly when sleeping. And again, that has to do with sleep apnea. And they can wind up with a hypoxic pulmonary vasoconstriction, which leads to a pulmonary hypertension, that's high blood pressure in the lungs, as well as hypercapnia, that's increased PCO2 in the blood. Obstructive sleep apnea, which results from the temporary airway collapse at the level of the tongue or soft palate, is highly correlated with obesity and also with hypertension. When we ask patients in a simple pre-surgery, for example, we'll ask them pre-surgically, what is their collar size? And patients with a collar size greater than 17.5 have a higher propensity towards sleep apnea. They also have a higher insulin resistance, a higher degree of coronary artery disease, and congestive heart failure, which leads ultimately to increased high blood pressure, insulin resistance, coronary artery disease, and congestive heart failure. So overall, the increase in both morbidity and mortality, that's how often we get sick and how often we die, can be seen with increase in coronary artery disease, hardening of the arteries and hyperlipidemia, high blood pressure, congestive heart failure, sudden cardiac death, peripheral vascular disease, and as weight increases, all of these risks get higher. Pulmonary problems can have decreasing lung volumes, large chest, but a small lung volume is possible. So increased work of breathing can happen. You get higher airway resistance, higher chest walls, decreased respiratory compliance from your respiratory system, flattened diaphragms, altered lung volumes, and ultimately an increased energy cost of breathing. It takes more energy to keep the body going. Some other systemic changes, increased cardiopulmonary compromise, potential for opioid administration can therefore cause hypoxia at a lower dose or carbon dioxide narcosis at a lower dose of narcotics. Morbidly obese patients state that he or she can sometimes only sleep in the upright position, or they might need excessive pillows, etc., to maintain a sleep pattern where they can breathe easily. Pulmonary hypertension or pulmonary high blood pressure, secondary to low oxygen then can occur. And we get pulmonary vasoconstriction, which leads to depressed heart function. So the work of breathing and the work that the heart is doing is having to be extra. That leads to decreased compliance by the lungs. For OB patients who are obese, they are considered high-risk pregnancies. There's a higher amount of infertility. There's disrupted menstruation and ovulation. That can happen because estrogen and female hormones are stored in adipose tissue, and the regulation is difficult for the body. They can get early menstruation or urinary incontinence. Those who succeed in getting pregnant will have some abnormal labor. There is a higher rate of cesarean section. Very often, because there's excessive calories in the body, that leads to an increase in the child, and increased fetal size is also a problem for that child. They have a higher rate of preeclampsia and eclampsia, and they have a higher rate of gestational diabetes. In trauma, there's premorbid risk factor. There's interference with activities of daily living, such as the exercise that we already talked about, getting up and down stairs, etc. They have a higher degree of displaced ankle and elbow fractures with minimal trauma due to a higher degree of weight on those joints. And they're also less likely to wear seat belts during trauma because they are poor fitting or they don't fit and they haven't paid extra money for a enlarged seatbelt. Subcutaneous fat, it's very difficult sometimes to hide physical findings. The more obese an abdomen is, the more space between your fingertips and trying to palpate what would be considered normal palpation of the abdomen. If there's more fat there, it's harder to actually find things. And that goes for simple things, like starting an IV or palpating an injury. Head injury protection and blunt trauma happens more often because these folks tend not to wear their seatbelts. There's a higher incidence of chest injuries for the same reason. They wind up with what we call a physiologic airbag, where the excess adipose tissue acts as an airbag. They have a higher amount of rib fractures and bruised lungs or pulmonary contusions, higher mortality due to respiratory causes, and higher incidence of pelvic fractures with minimal trauma. They're twice as likely to be injured in a vehicle for the same reasons that we just talked about. Very often, three-point restraints are not fitting well, so they don't use them. Increased risk due to increased risk of sleep apnea. Some of these patients actually can fall asleep while driving. Higher mortality rates in obese patients following blunt trauma for the reasons that we just talked about. They have a higher rate of thoracic and lower extremity injuries. They have somewhat lower rates of head injury because of the physiologic airbag that we talked about. But they do have more infectious complications because they tend to have a higher rate of diabetes and therefore they don't fight infection as well, and higher rates of death from respiratory complications of trauma.
At the London clinic, Charles is wishing that his patient had eaten a bit less.
Oh, he's fat. He's a fat boy. I've got that much fat between me and the spleen, and there just isn't it's just not nice. And we surgeons like thin patients. We don't like fat patients. You're not doing yourself any favors coming into surgery fat. Everything is difficult to move and it bleeds and just gets in the way. Look, you know, all this stuff is stuff we can do without. And it just makes it very difficult. Ah, there we are, okay. And that's what we were trying to do. Oh yes, that's nice. Big scissors, please, sweetheart.
His patient's size has forced Charles to abandon keyhole surgery and open him up. Now he's having trouble finding the right equipment to keep his patient's mounds of fat out of the way. He needs a kind of spade called a Morris.
Can we send for the National Lottery and see maybe they could fund us for another Morris?
Can you give me another Morris, please? If not, Mr. Ackle will...
No, Mr. Ackle's being terribly polite.
We'll be jumping up and down.
Ah, a Morris! My goodness, matron, thank you very much indeed for this Morris. May God bless you and preserve you, your children, your children's children.
Okay, so that is one surgeon who had to abandon what they called keyhole surgery. We would call it laparoscopic surgery, and do an open procedure because there was just too much adipose tissue in the way. When we have in our system, we have 2 bariatric surgeons in our system, and they have the highest degree of risk factors with their patients. Morbidly obese patients, we're talking about people in the 400, 500, 600 pound range, are very difficult to work on. So they have a higher degree of complications, and they're all considered high risk. Most of them wind up in the ICU after their bariatric surgery. Thankfully, there are bariatric surgeons who are doing, staplings and things, what are called Roux-en-Y procedures, causing, bypass, essentially gastric bypass, to help these folks lose weight. So what are the pre-hospital challenges? We talked about the general medical challenges. What are the pre-hospital challenges? And essentially, there are delays due to problems in moving and transport, like we already talked about, cutting the side off a house. Appropriate size gurneys, which we'll talk about towards the end of our talk. Excessive tissue impeding access for giving blood pressure and taking blood pressures. Mobilization and manpower. I'll talk about special units in a few minutes. Some towns, if they're large enough, have actual higher response units for the obese patient. Managing airways is extremely difficult, and I'll talk a little bit about that in a few minutes. And pulse oximetry is difficult because you can't get an accurate reading. Pharmacology, because of adipose tissue, increased volumes of distribution of lipophilic drugs, which many of them are, result in lower peak serum levels and longer clearing time. So the higher fat content in the body, when you get these lipophilic agents that attach to fat molecules in the body, it's very, very difficult to regulate our standard doses. Increased creatinine clearance compared to non-obese adults can decrease levels of drugs that are cleared by the kidneys. Alterations in the cytochrome P450 system have been identified in obese patients, therefore having increased and decreased activity of enzymes that break these medications down, and you wind up overall with a decreased tissue perfusion in obese patients. Lower concentrations of antibiotics in the skin and soft tissues, for example. Very often, there are challenges in obesity, and there are formulas for calculating ideal lean and adjusted body weights. So most of us are not talking about the freshman 20 or the midlife 40, whatever you want to call it. These are not, although those are not healthy lifestyles, we're talking about mostly morbid obesity. So ideal body weight for males, there's a formula of 50 kilograms plus 2.3 kilograms for each inch over 5 feet. And the same for females, about 5 kilograms less. Remember, a kilogram is 2.2 pounds, so the majority of women lay on average about 12 to 15 pounds less than a man. So an example, a 5'6" male should weigh somewhere between 141 pounds and 182 pounds, lean body weight. Now keep in mind that there are some 141 pounders who are thin and what we call, like a beanpole type of person. And there are people who have larger muscles, who have lifted weights or wrestled or played football and have a higher percentage of muscle. So that's why there's almost a 40-pound differential for a healthy 5'6" male. Some airway challenges. Very often they're difficult to bag valve mask because of fitting, and we'll talk about that in a few minutes. They're more challenging with cervical spine immobilization. Very often we all use what we call a no-neck C-spine device, and they're adjustable, and sometimes our patients are just a head sitting on a shoulder because they're so obese, and it's very, very difficult to get a C-spine device on them. Mallampati scores, which I'll talk about in a few minutes. It's difficult to visualize the airway. Obesity is not a contraindication to rapid sequence intubation. This is the preferred method for most of our elective intubations for patients, but there are most definitely challenges when dealing with the obese patient. And it's important to assess and recognize the predictors of a difficult intubation and prepare accordingly. So here's a gentleman that we're talking about, no neck. This is a large head. on a set of shoulders. And this is the type of person where I would view them and go, man, this is going to be a difficult airway. I'm going to do my very best not to have to intubate this patient. I'm going to try positive pressure ventilation. I'm going to try CPAP and BiPAP. And then as a last resort, am I going to try and get this person intubated? If they have to be intubated, they have to be intubated, but there's quite a bit of difficult challenge. Now, there's a little bit of controversy out there right now about cricoid pressure, whether or not it's needed at all. But can you look at that neck and say that you could satisfactorily give cricoid pressure? Can you look at that neck and say that you could satisfactorily find the landmarks that you would need to do perhaps a tracheostomy, an emergency airway? So this is somebody who's going to be very, very difficult. These are our Mallampati scores, 1, 2, 3, and 4. These are what we hope to see. To the far left, a grade 1 when we go to intubate somebody. And more our obese patients, we're going to get nothing but a grade 4. And a grade 4 is next to a blind intubation. So we have our tricks, for example, in intubation, Lemon score, or look at the anatomy. We'll talk about the 3-3-2 rule on our next slide. Mallampati score, which we just looked at, that's their Mallampati score, all right? And then obstruction, are there things in the way like teeth and swelling, and what's their neck mobility? What's the neck mobility on this patient? Practically 0. So here's our 3-3-2 rule. The 3-3-2 rule is if we determine that they don't have 3 fingers between the chin and their neck, 2 fingers when we slide our hands down, and 3 fingers when we put them into the mouth, then it's going to be a difficult intubation. So you go back to this guy, and there's no way that you could get a 3-3-2 score. The Mallampati score we just talked about a little bit. It's about how much you see when you open their mouth. The obese patients are going to live more down here in the difficult airway, class 3 and 4, where we might see just a little bit of space and or no space at all. These are moderate to severe difficulty, and 1 and 2, of course, are felt to be no difficulty at all. With congestive heart failure and pulmonary edema, let's talk about this proposed case. So you're dispatched to a 49-year-old male with a history of COPD and congestive heart failure, who's called 911 because he can't breathe despite several home nebulizer treatments. The patient's wife states that he is wheezing and profoundly short of breath. So you arrive and he meets you at the doorway, and your patient is standing there waiting for you. And there he is. Okay, this is the guy that you're going to start thinking about alternate airways. Just like our friend a couple of slides back, large chin, no neck, large body habitus. We're going to start hoping that we can do something else like positive pressure ventilation, BiPAP or CPAP, to give this guy a breathing treatment and get him out of the danger zone. Let's talk a little bit about, while we're talking about rapid sequence intubation, we have something called the 6 Ps of RSI: preparation, pre-oxygenation, pre-treatment, paralysis and induction, placement of the tube, and then post-intubation management. Now, for most of us, we intubate with something called succinylcholine. If we were to properly oxygenate our patient, a non-obese, healthy patient, for 5 minutes, high flow oxygen, positive pressure ventilation, if we were to oxygenate them quickly, and then give them succinylcholine and could not get a tube in about 5 minutes, that succinylcholine would wear off. Most of our patients would be okay. So here's a desaturation curve. Let's talk about a normal patient who's blue. Here's our blue natural curve. So if we start with 100% oxygenation at time 0 of giving succinylcholine, round about 6 minutes, when we run out of time, we start to slowly drop off and our saturations drop. This is when we get into the danger zone. Now, the problem is with obese patients, here's our obese patients, that curve is much, much faster. Even more so than our moderately ill patient or children. So the obese patient is the first one to go down the slide and fall. That's kind of why I put the Eddie Murphy picture in of the lady going down the slide, to keep us in mind that we're going to have a faster fall off for our obese patient. Over time, oxygen saturations, here's our obese patient as compared to a healthy patient. They have a much steeper curve in minutes where they start to lose their saturations. Saturations over a shorter period of time. For all the reasons that we talked about earlier: decreased lung compliance, decreased lung volume, decreased rib size, all of that we talked about earlier. So assisted ventilation, intubated obese patients should be ventilated based on ideal body weight. So I showed you a formula based on ideal body weight. So if you have a 5'6" person, know that somewhere, if we put him at the upper limits of 180 pounds, would be ideal body weight, rather than total body weight. Because with total body weight, if we were to go with total body weight, we're going to have extremely high pressures when we put somebody on a ventilator, and we're going to wind up blowing out their lungs. So the use of 10 centimeters of positive end expiratory pressure is recommended in obese patients to improve oxygenation. As a positioning of the patient, we're going to try and put them in the beach chair position, head up, flex hips and knees. You're going to have to use cautiously in hemodynamically unstable patients. So EKG analysis. This is another challenge because landmarks for lead placement may be difficult to determine. You can result in inaccurate lead placement. Variation in fat deposits surrounding the heart and chest wall can lead to an inconsistent voltage changes, so you might not get an accurate reading of what's going on in the heart. You can wind up getting flattening or inversion of the T wave in the inferior and lateral leads in 50% of obese patients, because remember, T wave is simply repolarization of the atria, and because of the size of the patient, we may not have an electrical activity enough to penetrate the fat to pick that up. Corrected QT intervals are also something that we can see in obese patients. So here's a guy here, looks like he's more than just our freshman 20 or our midlife 40. He's working on a pretty good belly there. But there's also going to be more fat around the heart muscle, and that's going to lead to a higher degree of coronary artery disease. It's going to be difficult to get an accurate EKG the larger our patient gets. Simply taking a blood pressure is going to be difficult. We are going to get inadequate width and circumference, which can artificially elevate blood pressure. If we have a large arm, we have to use a large cuff. Sometimes we have to use what we call a leg cuff on some of our patients. And very often we're sitting there with a standard blood pressure cuff sitting on somebody's wrist, and that's the best we can do. And that's just not accurate. The cuff to arm ratio is usually supposed to be 2 to 5, and the bladder length 80% of the arm circumference. Sometimes we just can't find a large enough cuff. That's why it's very important to have a variety of cuffs. It's probably better to have an artificially low blood pressure and be more wary in a trauma patient or a cardiac patient than it is to have an artificially high blood pressure. Pulse oximetry, tissue thickness impedes the light wave transmission. So if it has, so very often we have to take it off the fingers and put it on the earlobes of patients. Other areas of placements are the earlobe, the fifth digit of the hand or foot. Sometimes we have to put them on the nose, lip, or temporal artery. We have to get very creative. Nurses are really good at figuring out where to get a good oxygenation for pulse oximetry. Venous access is going to be a challenge. Landmark vessels are not visualized or palpated easily. Some patients refuse to be a pincushion because it's hard to find. Multiple attempts, they get angry, which delays our access to the patient. We get higher complication rates with multiple sticks because we're introducing skin bacteria into the skin. We become less sensitive to sterile technique. We can wind up with a higher degree of phlebitis or thrombosis. And the standard 1.5-inch needle may not be long enough, and we have to go with our long needles and catheters preferred. Very often, when we get into these situations, we'll call down a special nurse who's an IV nurse who's very good at starting IVs, and she will use, almost always she, will use ultrasound to help identify a vessel.
Dr. Eschelbach?
Yes.
There's a question here. Would a patient with this much upper body mass, should we expect slightly higher PIP pressures to administer the VT because of the amount of force needed to move the chest wall to create room for the lungs to fill?
Yeah, that's a good question. So yes, you're going to have to use a higher pressure rate to fill the lungs. The one slide I showed was in an intubated patient and determining what their tidal volume is. So yes, you're going to have to use a higher amount of pressure to fill the lungs, but in a ventilated patient, when we're talking about a patient who's on the ventilator, we calculate their lung volumes based on their weight. And what that slide was trying to bring out was don't overestimate based on non-total body weight because you don't want to blow a lung out. So tricks that we do, applying heat, we do this often. We pull a blanket out of the warmer, lightly tapping over the vessels, pumping of the extremity, flexion and extension. Some nurses will use a little bit of topical nitroglycerin. I'll show you in a slide in just a minute about our interosseous needles, and we wind up with hyperemia where we can occlude a blood pressure cuff for 3 to 4 minutes and then release slowly just below the diastolic, and sometimes we'll see a vessel that way. IO needles, when they came out, they were 2 sizes. They were kids and adults. And standard adult was a 25 millimeter. And then over time, they found that with obese patients, they just couldn't do that. So they came up with this special yellow one that's 45 millimeters and actually works better in obese patients. So a large amount of edema or musculature or obesity, we use these larger ones. 45 millimeter needle set is needed to reach either the humerus or the tibia in obese patients. Here are the three sizes we had. Remember, Think Pink is for kids. They're small. Standard Adult for IO, and then the larger we use on our obese patients. I am seeing these used more and more for our difficult obese patients. We talked about delays in moving and transport, appropriate size gurney, tissue impeding access for giving fluids, mobilization and manpower. You have to have enough people to actually lift the stretcher, managing airways and pulse oximetry. These are all that we talked about. And here are two examples of our standard models. And you can see that they actually now have a larger model. I'm seeing more of these for an up to 850 pound patient, or this model here, which is up to 1,600 pounds. I can't imagine how much these cost. These stretchers strikers are expensive enough, but I have seen them at shows, conferences, and they have these larger ones. What that'll lead to are these pre-hospital challenges where they have to have actual increased ramps, specialty ramps to get a patient in. If you can't do the standard lift, even a heavy patient or 2 or 3 or 400 pound patient, it might take 4 paramedics to get them in, or you may not want to do that at all and you get these special ramps as a solution. Here is a standard ambulance on the left, and in places like Portland, Houston, Los Angeles, Orlando, where there's quite a few of higher percentage of money and a higher percentage of paramedics, you're going to have the rig on the right, which is actually designed for the obese patient. So sometimes the initial first responders come out and they might have to say, we're going to need the big rig, and the second team will come out, which has the special devices that they'll need: a larger stretcher, larger ambulance, and a higher capacity. Transporting people in a manner that's safe for both personnel and their patients, in a manner that's also very respectful. In 2000, their injuries related to transferring obese patients were 50% higher and 50% of workers' compensation annual costs. 2 to 3 people are available to move a patient from one spot to another. Just one injury could mean the end to an EMT or a paramedic's career because of a ruptured disc or something like that. In the hospital, we have overhead Hoyer lifts that are built into every room, and they have a capacity of 500 pounds. Sometimes we have a patient who's heavier. So you must conduct pre-planning exercises to prepare for attending to these special situations. And very often we don't get this. We don't think of the problem until we meet the situation. So we have to have actually in our protocols, policy and procedures dealing with obese patients, continuing education. We have to make sure we ask our colleagues to give us lift assistance and use equipment that helps patients without harming the workers. Even with the best of intentions, treating and transporting morbidly obese patients will take more time, more money, more resources than any other type of call that a paramedic may respond to. Current education, EMT paramedic curriculum is minimally covers the obese patient. So unless I'm wrong, you may not have had any lectures in how to deal with the obese patient. That's why I bring it to you today. Teaching such accommodations may be necessary and get you to start thinking for the future. need to use appropriately sized diagnostic devices like we talked about for blood pressure and spirometry, etc. Maintain professionalism at all times. It's difficult to do sometimes, but we're going to be very, very respectful to the patient if we can. And note that the paramedic may require additional assistance. It's labor intensive. The equipment is expensive. You want to avoid unsafe transport. You want to avoid undignified transports. And you're going to avoid medication problems. And you're going to have to avoid bias, because most of us have a certain bias against these patients. And these patients, that's why they don't come in. That's why they don't go to the doctor, because they feel that there's a terrible bias against them. And why go in and get humiliated? And that's not the best way to have a healthy lifestyle. And that's why we need to help them. There are some specialized learning modules for the obese patient. I would encourage you to take a look at them and be sensitive to them. It's difficult. And again, the best way to look at things in my mind is with a smile and a little bit of a chuckle, and then move forward to see how you can take care of the patient.
Oh, this is so fabulous. Ain't nothing like getting together with family and having a good meal. Oh, please take this bowl. It's hot. I am hungry.
God damn, Sherman, it's almost like we don't see your ass no more. It's good to see you, son.
Yeah, Sherman, you think you two Joe College good to spend a little time with your family every now and then?
Well, I've been real busy with my research.
I don't want no potato. You know mashed potatoes give me gas. You know, in my day, Sherman, people used to spend time with their family on Sundays and special occasion, come around and pay their respect.
You mess around and miss all little Ernest golden years, magic golden years, and you're gonna be mad at yourself.
Okay, so references are here. There's quite a few online references for treating the morbidly obese patient, and there are challenge, and we have to make sure that we are up to date as best we can. All right, that's the end. I'll open up to questions.
Looks like Shannon has asked, I'm curious why the bariatric stretchers are not hydraulic.
I believe they are. Let me see. There they are. I believe the ones that I've seen, they have a gear on them. And this one has a gear on it as well. I believe they are hydraulic. I mean, the ones that I see, the standard ones I see that come out, especially the strikers, all they do is get them to the edge of the ambulance. They push a button, the wheels come down, and I'm sure that these are the same. I would guess that these are the same. These are got some heavy pistons on them. And the ones that I've seen at shows were hydraulic.
I think it boils down to some are designed not to be. It depends on the weight of the patient, I believe, as far as what they're rated for. I think some of the ambulance units are designed in such a way that there are different methods for some of the stretchers to be loaded for the extremely morbidly obese patients. But, you know, it depends on what it is that you're outfitted for and which brand. I think they're all kind of different out there.
Would it be possible to interject there for a second on that? I worked in Orlando, and we had the bariatric stretchers, and the ones that Stryker had, they're not the battery operated. They have hydraulics to get them up and down, but not automatic. You have to manually lift them still. And they were mostly meant to keep with the patient on it all the way down at the floor level and roll them to the ambulance and then use the ramps to get them in. So that you're not risking, because putting it up, you're risking to drop the patient with all that weight because it becomes complicated.
Thank you.
Very good, Lewis. Anybody else have anything else they'd like to say? I've got Gary says, it seems like the approach to these patients from a cardiopulmonary standpoint is similar to the approach to treating a child with hypoxic congenital heart defect, left to right shift,
right,
if I remember correctly. Is that right?
Yeah, a lot of these have left ventricular hypertrophy leading to almost like a heart failure type of patient. What is amazing to me is really how the body compensates over time. So these patients, they don't go from 200 pounds to 800 pounds overnight. They do it in such a slow, incremental fashion, almost like the news article said. You know, I took care of this guy a couple years ago, and he was a fine tenant, and now he's glued to a chair. So it takes a very slow amount of time to become so obese, and the body compensates with that over time as well. So they are going to be heart failure patients. They are going to be like hypoxic children patients because of their primarily decreased ventricular function.
Clayton wants to know if you have any opinion about why insurance companies do not make it easier to get gastric bypass or other bariatric type surgeries, because it seems that it would save money down the road if it's easier for them to get smaller and healthier.
Absolutely, I agree. I would say that bariatric surgery really should be a last resort. It's expensive surgery. It's extremely expensive surgery. And the problem with bariatric surgery is they have a high complication rate. These are the highest complications in all of medicine when we get these people. When they get abdominal pain, the first thing they do is get a CAT scan because they have leakage, they have failure of their bypasses. It would make a lot more sense to save that money up front. But isn't that what preventive medicine is about? And we spend a whole lot more on reacting to things than we do to preventing things. And I think that's our country and medicine in general, without editorializing. So I think that's a very astute observation. And some of these patients are embarrassed. I am surprised as I take care of patients, they'll see somebody who's 180 pounds or something like that, and they say, well, I used to be 500 pounds until I got my bypass surgery. And I just think, well, good for you. That's a whole 2 patients that you lost, 2 people that you lost. So these people are usually motivated once they get the surgery. Getting it approved is sometimes difficult.
And Jonathan says, isn't there quite a bit of relapsed obesity with bariatric surgery too, without a lifestyle change?
Yeah, you have to have, it's a whole package. You have to have smaller meals, frequent meals. They have to learn how to use protein, stay away from fats and carbs. It's for most of us, it's a lifelong fight, except those couple of people that I talked about who are just genetically born skinny. And they are that. One of the guys in our group, one of our ER docs, comes in with a dozen donuts every day, eats a dozen donuts every day. And we kid with him, but he's as skinny as a rail. We say he's got some kind of tapeworm inside of him, but that's just him. But he has a brother who has obesity. So it's just whatever happens metabolism-wise, it's very, very difficult.
I'll make a comment here. I've had several friends and coworkers that were morbidly obese, and every one of them were insulin-dependent diabetics. And after their bariatric surgery and their weight came down, they went down to oral agents and eventually came completely down to diet controlled, all the way from insulin-dependent to nothing.
Yeah.
It's rather dramatic. Okay, ladies and gentlemen, do you have anything else for Dr. Eschelbach tonight? Looks pretty quiet. Let's see. I know some of you still here. Daniel, are you still here? Yep, he's still here. I'm just making sure everybody's still here for credits. Louis, Priscilla, I saw you earlier. I know you're still here, right? Louis is still here. Yep. Okay. Well, if we have nothing else, then I've posted the credits for those of you that need the credits for your Paramedic 2 Roundtable. Dr. Eschelbach, thank you for joining us tonight and helping us out with this. This is a really, really great subject.
All right. Thank you very much. Thank you, everybody. Have a great night. Stay warm. Stay out of the cold if you're in a cold place. Good night, Jane.
Good night.